Hi, my name is Shauna Fahy and I am the Antenatal and Newborn Screening Specialist Midwife or Screening Coordinator at Chelsea and Westminster Hospital on the Chelsea site. My presentation for you today is going to be about donor pregnancies and other special circumstances in relation to screening for sickle cell and thalassemia. In the past few years, we have seen an increase in the number of women who are booking their care in London and pregnant with a donor egg. And in our hospital, our screening team counselled 81 women pregnant with a donor egg in the last year alone that we're aware of. And the reason I say that we're aware of is because we know that there have been a number of incidents reported where appropriate screening for sickle cell and thalassemia has been delayed when it wasn't identified until later in pregnancy that it was a donor pregnancy. And we know that some midwives might not actually have had much experience dealing with screening for sickle cell and thalassemia in donor pregnancies, and they may not know what they need to do that's different to screening in a pregnancy where it's the woman's own egg. So I'm going to focus on that today. And as I said, I'm also going to touch on some other special circumstances around screening for sickle cell and thalassemia. And as Helen said as well, if you have any questions, just put them in the chat and I'll try to answer them as best as possible. So just to give a bit of background information about screening, there are 6 NHS antenatal and newborn screening programmes that I'm sure you're already familiar with. And screening for sickle cell and thalassemia is one of those programmes. And the main aim of this screening programme is to identify babies that are at risk of inheriting a major hemoglobin disorder, so i.e. sickle cell disease or thalassemia major. So why screen? Why would somebody want to know if their baby is at risk of a major hemoglobin disorder? So it may be just for information purposes, so that parents can prepare themselves for the possibility of having a child with a major hemoglobin disorder, because these are lifelong conditions and they can require extensive medical care and treatment. Or it could be so that they have the opportunity to have prenatal diagnosis to confirm whether or not their baby has the condition, and then they have the choice whether or not to continue or to end their pregnancy. So just to give you a very basic run through of what hemoglobin is. So hemoglobin is a substance that's in your red blood cells in your blood, and it carries oxygen to all of the cells in your body, and it's made up of 2 alpha globin chains, and a mutation or a deletion in the alpha globin chains causes alpha thalassemia. It's also comprised of 2 beta globin chains, and a mutation of these chains causes sickle cell or beta thalassemia, and it also has heme molecules that contain iron. So what are hemoglobinopathies? So they are recessively inherited hemoglobin disorders or blood disorders, and they are caused by over 1,000 hemoglobin mutations or genetic changes. They can be split into 2 main groups. So these are the hemoglobin variants, so for example sickle cell, which affects the structure and the quality of the hemoglobin that's produced by the body, and then the thalassemias that affect the quantity of hemoglobin that the body can produce. And hemoglobinopathies are more common in certain ancestries or ethnic groups, but theoretically anyone can be at risk. But my colleagues will talk about these in a bit more detail later. So how are hemoglobinopathies inherited? So we've already briefly mentioned that they are recessively inherited. So this means that in order to inherit a hemoglobin disorder, you would need to inherit the unusual gene or mutation from both the egg and the sperm. If the unusual gene is inherited from one of your parents, and then the usual gene is inherited from the other parent, then a person is considered to be a carrier. And carriers are generally asymptomatic, or we can refer to them as healthy carriers. So I'm not sure if you can see my mouse here. So this is the unusual gene, and this one here is the usual gene. So let's say, for example, if the parents are both carriers, let's say both carriers of sickle cell, for example, for every pregnancy that this couple have together, there will be a 1 in 4 chance that the baby could have a major hemoglobin disorder like sickle cell disease. There will be a 2 in 4 chance that the baby would be a healthy carrier, and then there'd be a 1 in 4 chance that the baby would have inherited just the normal genes from both of them, and they would not be affected. So it is very important that we know to ask the right questions at booking, so that we can appropriately screen for sickle cell and thalassemia for the baby. So if a pregnancy has been conceived with IVF, it's really important to ask if it was with her own egg or with a donor egg, and then obviously also importantly, if it was partner's sperm or with a sperm donor. Women might not want to disclose if a pregnancy has been conceived with a donor. They might worry that they might be judged or treated differently, or that friends or family might find out if it's written on their notes. But it is really important that we explain why we're asking the question. So make it really clear why it is important and relevant for her care. So we would explain that inheritance of hemoglobin type is genetic, that a baby will get one type of hemoglobin from the egg and one type from the sperm. Hence why we need to know if it is her egg or donor egg, and why we need to know if it's the sperm donor or the partner's sperm. Because we know if it's a donor egg, then it'll be the donor's hemoglobin type that passes on to the baby rather than the pregnant woman's own hemoglobin type. We need to make sure that we record that it's a donor egg on the family origin questionnaire, and this is the form that we need to complete when we're ordering hemoglobin electrophoresis blood test at booking. And I'll just show you quickly. You can see that there. So most trusts will have an electronic version of this on their system that they request bloods from. So right at the bottom of this form here, it shows you where it's donor egg and sperm. So it will be really important that you would select that when you're requesting the bloods. If the pregnancy has been conceived with a donor egg and we record the pregnant woman's family origin on form, we're actually not providing a risk assessment for the baby, because the lab won't know that it is a donor pregnancy, so they won't alert the screening team. So then we won't know then that we have to contact the woman to discuss testing the baby's biological father. So what would happen is, if her result was normal, the lab would issue a normal result and no recommendation would be made to test the baby's biological father. So the baby's risk of sickle cell or thalassemia would not actually be assessed. It's also very important to tell your screening team at booking if a pregnancy has been conceived with a donor egg. And if you don't know their contact details, please do find them out. We know that people who work in labs are human as well, so we can all make errors. If you tell your screening team when you book a woman who's pregnant with a donor egg, it's an extra fail-safe to make sure that it's not missed. And it means that your screening team can just contact the woman straight away without having to wait for the lab to process the result, and then the lab to contact the screening team with that result. So then just moving on to testing the baby's biological father. So it is very important to make it clear why it is specifically baby's biological father rather than the partner that we need to test. So this could be because maybe it's a sperm donor, or the pregnant woman might not actually be sure who the baby's biological father is. And we have had cases where a woman has a partner, but she's not sure if he's the baby's father. So this can be a bit of a sensitive subject, and we have ended up screening more than one man for a pregnancy. But we know that if we screen anybody other than the actual biological father of the baby, we're not actually providing a risk assessment for sickle cell and thalassemia for the baby. So it is just really important that the woman understands the importance of why we need to know the biological father rather than just her partner. But this is also really important if a woman is a carrier of sickle cell or thalassemia, and we're recommended to test the baby's biological father. Again, we need to make sure that it's the biological father, not just the partner, that we're testing. So if the biological father has actually been screened previously, it is still recommended to repeat the testing in this new pregnancy. So it's recommended to test in each new pregnancy. And we want the most up-to-date result possible, and we want to be able to verify the previous result for a few reasons. So it's unlikely, but there is always the possibility of human error in the lab or wrong blood in the tube with the previous sample. Advancing technology in the labs can mean that we now may be able to detect hemoglobin variants that we weren't able to detect previously. Or there could be a change in lab processes or the screening pathway processes. So, for example, we had a pregnant woman who's found to be a carrier of alpha-0 thalassemia, and she asked why we hadn't picked this up in her previous pregnancy. And when we look back at her family origin, it had been recorded as any other Asian family origin in both pregnancies. And we found that this further DNA testing hadn't been recommended with this family origin. But in the time between her two pregnancies, the guidance had been changed to recommend that DNA testing should be carried out on this family origin. And DNA analysis or DNA testing is actually the only way to confirm alpha-0 thalassemia, and how the lab knows whether to send a sample for this test or not is by family origin, so it's really important. So in this case, it shows why it is so important that we did repeat her sample. So we tested the baby's father, and he wasn't a carrier, so the baby was not at risk. But it just shows you, you know, each new pregnancy, things might change, so it's best just to repeat testing each time. Equally, even if an egg donor has been screened by the fertility clinic, it is still a national recommendation to test the baby's father. So, you know, it's important to be aware that not all countries will offer or screen donors for sickle cell and thalassemia, or they might not screen for all of the hemoglobin types that we would commonly screen for in UK labs. And this is really important because we do have a lot of women who have had fertility treatment abroad and then obviously come to us in the NHS for their antenatal care. So this year we have had a woman who is pregnant with a donor egg. She had fertility treatment abroad, and neither the baby's biological father, who was her partner, nor the egg donor were screened for sickle cell or thalassemia. We screened her partner, and he was actually found to be a beta thalassemia carrier, which caused them an enormous amount of stress because they were under the impression that everything had been screened for. But we just don't know from one clinic to another or one country to another what they're actually required to screen for. So yeah, that's why it's important that we need to offer that to the baby's father, regardless of what screening has been done by fertility clinic already. Then, so prenatal diagnosis. So if we have a situation where there are no screening results available for either the donor sperm or egg, then the process for dealing with this situation should really be determined locally. So we need to have a discussion with the multidisciplinary team, you know, maternity services, the specialist nurse, and consultant hematologist. And if it is deemed appropriate, we can offer prenatal diagnosis, so either by CVS, which is the chorionic villus sample, and that's something that we can offer from about 11 or 12 weeks, depending on the fetal medicine unit, or an amniocentesis, which we can offer from 16 weeks. And with both of those procedures, there is a miscarriage risk of about 0.5%. So we really need to weigh up the risk of miscarriage against the risk of the baby inheriting sickle cell disease or thalassemia major. So that's why it's quite important to be able to have that discussion with the MDT before going ahead with that. As was the case with the couple where the partner was found to be a carrier of beta thalassemia, but the egg donor's status was unknown. So just want to talk about other special circumstances that I said I would talk about earlier. So you might not actually come across these situations quite as frequently, but it is very important to know what to do. So if either biological parent was adopted, the family origin information might not accurately reflect the true family origins. So these cases should really be treated as high risk and have full laboratory screening. The next one there is surrogacy. So it's really important that we test the pregnant woman, because obviously if she is a carrier of thalassemia, it's important that we know for the management of her care regarding her hemoglobin level, when to give her iron tablets, etc. This is also relevant for donor egg pregnancies, that we do need to test the pregnant woman as well. But for surrogacy, then we need to test the baby's biological parents for the baby's risk assessment. For donor egg and sperm or donor embryo, we need to contact the fertility clinic to establish if the donors have been screened for haemoglobinopathies. For a stem cell or bone marrow transplant, The hemoglobin type, when we do the blood test for the woman, will likely be that of the donor. And so we would need to offer testing of baby's biological father, because again, we wouldn't be providing a risk assessment for the baby. Gene therapy. So this modifies a person's genes to actually treat or cure disease. So it is likely that the result will be misleading. So if a pregnant woman has had gene therapy, then we really do need to offer testing to the baby's father. And then finally, a recent blood transfusion in the last 4 months. So again, the hemoglobin type of the woman, when we take it, will actually be the hemoglobin type of the donor. So we need to know the date of the transfusion, the reason and the place of transfusion, and it will be recommended to test baby's biological father as well. But obviously, anything that comes up in any of these special circumstances, or anything that I've talked about already, it would just be really important to get the details of your screening team and get in touch with them, and they'll be able to guide you in the right direction. And I suppose I just want to finish on, if you know that a pregnancy is IVF, just think donor. Is it a donor pregnancy? And yeah, there's just my references. So if you have any questions at all, please do put them in the chat, and thank you for listening.